It's a patient, 53 years of age, female, a BMI of 17. She was suffering from intermittent left-sided gluteal and leg pain since 2021. Since 4 weeks, the radicular pain increased. The MRI, now from 2 days ago, shows us this left-sided disc extrusion, L5S1, a compression of the S1 nerve root. So we routinely here also do a standing X-ray. It demonstrates very nice, a very wide interlaminar window, L5S1. So if we look at our classification, this is a surgical complexity of 1A. It's an easy access interlaminar window, L5S1. We expect to be a soft, maybe medium soft disc herniation, and it's an interlaminar approach.
Okay, so we get started. So usually I just do an AP view for a L5S1 approach, right? So I have already palpated where I think I would go. From open surgery, I would just cut, right? But with endoscopy, you have to be much more precise. So make a shot, please, here. Okay, so we're at the 5-1 level. Here, this is the line. But then let's open up a little bit like that, and then take the needle now. Okay. Let's take a look here. Shoot, please. Okay, now you see beautifully the 5-1 window. And I like to, so this is a disc herniation which is not sequestered downward or upward, right? If it would be downward sequestered, I would go to the lower lamina. And if it's upward, I would still go to the lower lamina, but just aim towards the upper lamina. But the landing point of the needle is always the upper lamina, right? So question is where to put the incision. For that, we make orthogonal view. Shoot again. I'm going slow to just show you everything. Okay, so this would be rather low. From mediolaterally is exactly where I want to go, so I go with the vertical line. Shoot once again, I go a little bit higher. Okay, that's where I want to enter, okay? Because remember, the scope has angulation in view, so if I go from up down, it's easier. So this is my entry. I just turn my hand and I go in. Now, I want you to see that I don't go in orthogonally, okay? I don't go in orthogonally. I go a little bit like that. I aim high so that I aim towards my upper lamina. Rather, I want to have a upper lamina contact. So now I have the upper lamina 20 degrees up from here. Shoot, please.
So Mazda, for the participants, I noticed that you changed the angle of the beam for the X-ray. So you changed it first to kind of look at the interlaminar window, but then you went back to the AP. So can you explain your reasoning for why you tilt it for the rest of the people who are attending?
Thank you very much. Great question. So basically, I do 20 degrees downward to be sure that I have the right level and so on, right? Just for better identification. And once I have that, that's it. I want an orthogonal view because my orientation of my instruments is orthogonal. That's why. So, and then I can also calculate my angulation of the needle. Otherwise, you have to do a lot of math. You have to say, well, 20 degrees watching that. I want to have a 20 degrees angulation that ups to 40 degrees, and it's just much more complicated. So that's actually why. So we start. I now do the skin incision. I do that with the needle in. And now you have to watch that, please. I glide my knife at the needle down to the fascia, and I cut the fascia. If you don't do so, the fascia is not cut. After I've done that, I use the guide wire, and then you can either go one step or dilate. You know what? Let's go one step here.
Is there any preference for one step versus dilation for you?
Good question. So lumbar, I don't really care. Cervical, I like to dilate because of the muscles. How about you?
Yeah, exactly. For lumbar, I like to just go one step. I think it's a little bit faster.
Yeah.
But actually for cervical as well, for cervical, I do like a bigger instrument because that way I won't be diving into the interlaminar window. So
Yeah.
I like to have a thicker instrument so that I can kind of really palpate if that.
The cannula you see here, the opening aims medially, okay, and then I go in, and the cannula is sharp. So this is an important step to just do like a cup-like maneuver to scratch away the soft tissue from the lamina, the upper lamina, not all of it, just a little bit, until you kind of click in. And this is the click we want to have. So it goes like, look at my hands, it goes like down, 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 click, and now I'm in. And now the cannula is kind of fixed, right? Once the cannula is fixed, I can remove that and just verify the X-ray. Korkklemme bitte und BV inne. Verify an X-ray to have a bullet eye view on the interval. Okay, Schuss? So that's what I want to see, okay? So here I know I'm at the window, in the window, right? And this is now, this is the X-ray I document for medical legal reasons. And once I have that, I go in. Okay, BV zurück. You see that I have a tissue glove here. This just makes life easier. So I fill the cannula, and then we go in, and that's how it starts.
Mazda, only one more question regarding the radiograph. You check also in the lateral view, or you just go with an AP?
Bonjour. I don't check the lateral view if it's such a clear situation on L5S1, right? So no, I don't check the lateral view. Do you?
Yes, especially in the hyperlordotic situation,
Mazda?
I try to do a lateral view just to check, and I trust that a little bit more.
Ah, yeah. Thank you. Okay.
I also use the lateral view. I have had some, when I first started, I think when the beginners are maybe doing this, if they don't get it lateral, sometimes you can be caught on the fascia or on the spinous process, and you start drilling and you didn't get a lateral, and then you just wasted 30 minutes of your time drilling spinous process. So I think for the people who are first starting out, I think, Mazda's an expert, but for some people who are starting out, I think getting a lateral, one, helpful to make sure you're at the right target location, and two, medical legal, you're at the right level, right? That's also very helpful. And then just making sure you're in the right spot, getting 2 images.
So I like to remove the fat tissue here before I coagulate the muscle. Here I can do that nicely with the shaver. Beautiful. Now all fat tissue is gone. Nach zum Brennen ist da. Okay, let's get going then. So, I don't want to disturb too much muscle, but that's, if you look on the MRI, this patient has a lot of muscle, right? So, let's take away all this muscle up to the level of the flavum, of course. So down here we start to see the flavum. Sometimes after coagulating the muscle and cutting the muscle, you see another layer of fat here. Shaver, please. So I can remove. So that's what I want to see. That's already it, right? So that's a very safe and traumatic way to see how fast the window is visualized.
Mazda, did you break the table at the level L5S1 in this case?
Yeah, I did a little bit of flexion, but the window is large, so I didn't care that much. So now I create my trampoline. We call it trampoline here, right? So if needed, you could go up and now visualize the, the lamina up here, but it's not needed. Why should I do that? I have here, this is the trampoline effect. I could go and palpate my lower lamina, which is here. And I could go up, and this is my upper lamina, so the cranial one. So large window, nice window. Get enough exposure, but that should be actually enough. I could go a little bit more lateral because the nerve, as you have seen in MRI, is visualized laterally. And see how I use the coagulator to already get rid of the first layer, because there are always 2 layers, right, of the flavum at 5-1. And so these are now, this is actually getting thinner and thinner. Rangeur, klein bitte. Please, from the faculty, if you do it differently, just let me know. Here, before I cut, I turn my scope a bit. Here I'm in already, see? You could have used the scissor too, but since I'm pushing, so I'm pushing with the cannula, right? That's why the flavum becomes really thin, and therefore, I mean, you could play around with the scissor, but usually I don't even need it. Give me a scissor just for demonstration, a curved one, please. So what I like sometimes is just to make sure that I have enough lateral exposure. So when you cut, please make sure that you see what you're cutting. So it would be a good idea. You can either go 90 degrees or 45 or whatever. Just make sure you see what you're cutting here. I'm doing it in a slow way so that I can visualize that. See how it jumps up now? That means I'm on bone. So the tip of my scissor is on bone. This is now bone, right? Okay, now we are intradural.
So Mazda, now that you're seeing the thecal sac and the fat, do you change your settings for the bipolar, or do you keep it the same setting you initially had it on? What are you doing?
No, I will. So I have 2 buttons on my bipolar, right? One which is basically kind of a aggressive one, cutting one, and one is coagulation. So when I'm going in here, I use coagulation.
But what number setting do you typically put it on for the
Well,
frequency?
it depends on which company you have, right? We have a standard setting, 50 for 50 actually, and there are 2 modes, I guess, of the bipolar frequency, you know. So see how we're seeing already the dural sac here, and there are some ligaments. I recently learned that it's not totally right to call them Hoffman ligaments, because Hoffman described in the 80 something, he just described the ventral ligaments, not the dorsal ones. So you can still describe them and you know, have a name on that ligaments there. So I use the shaver to get rid. Here we have a little bit of fat tissue. That's a very safe way to visualize the situation here, because otherwise it might be not as easy. Here we just suck the fat tissue, and as you see, it's not dangerous, so I can go against the dura even, and you know, I can do that in a beautiful way. That's it. And we see already here this herniation. Now, Häckli bitte. So I give you the overview. We're looking at the nerve, okay? Since my cannula is angled, even if I push down here, I don't impinge the nerve. That's important to know, because it looks as if I would impinge the nerve, but I don't. You see how it's still free here. I can now do the turning maneuver if want. Here we have the disc herniation already. So I like to do the turning maneuver just to display the nerve, and here we are at the disc herniation. Now, before removing the disc herniation, you know, people get happy and remove that fast. Just be sure to visualize the nerve root. So you see at 1 o'clock the nerve root. Be sure you have visualized it in a good way before removing stuff, right? Rangeur bitte. Yeah. And yeah, so first we will take some fat tissue again. And here we are at the disc herniation already. So this is the disc herniation, removing the disc. Shaver bitte. If I don't have a nice overview on the disc, I want to get rid of the tissue which is not disc. I try to make this surgery a little bit less boring because actually it's a disc herniation surgery. So dear colleagues, faculty, what would you do differently, or what are the nuances that you want to share with our participants?
So I think I pretty much do everything you do. I think one nuance I think is, this herniation is big, but it's not axillary disc herniation, which could kind of trick you sometimes, because sometimes you think you're lateral to the traversing nerve root, but actually you're in the axilla. So
Exactly.
what things do you do to make sure that, let's say that herniation was really, really big, and then the second you cut through the flavum, all you saw was the lateral edge of a nerve, but you're not sure if it's thecal sac or traversing nerve root. What do you do to make sure that you're in the right spot?
Very, very, very good question. Because if you look at the MRI, the situation could be like that, but it is or a little bit too nice to be like that. So I'm still expecting a nerve root laterally, right? So I have to expect that. But before going and checking that, I remove the free fragments because they will occlude my vision. But to make sure, basically, what we do is we visualize the pedicle, or at least we palpate the pedicle, right? And that's something we still have to do because, it could be what we have seen could be either lateral dura and not nerve. It could be a high-riding S2. So this is all possible, right? So, we have to make sure that we don't have any other tissue going on here. But I will do that in a second to check. I mean, the other option is to go and search really for the axilla, but still it could be S2. So I think there is no other way than looking laterally, right? And this is how you can look laterally. So you basically turn your scope, häckle bitte. Let's see. And we go search for the nerve once again. So nerve here. Right, we turn our scope. This is ligament here, and now we can turn even more, looking towards the pedicle. Now I'm trying to palpate the pedicle, which is here, but I'm still not 100% sure, right? Whether, so, putting, now the hook is on the lateral, and my scope is turned 180 degrees, so I'm looking towards laterally and pushing laterally and checking for any neurological tissue, but I'm not seeing any so far, right? So I think I'm safe, but I will just pull stuff that I know is disc. I will not pull something else.
So it's funny, we always joke about sometimes when we find out the hard way that you're in the axilla, is that we call it the leg jump sign. You take your bipolar and you kind of you go laterally, and then the leg jumps. You're like, okay, that's not supposed to happen. So you're probably in the axilla. I don't know if any of you have experienced that.
Neuromonitoring.
Yeah, neuromonitoring.
So look at the disc here. See the fragments. I mean, we knew that it's not gonna be one nice disc because it's an older story, but we're getting it out here. So now I'm holding the disc. Something that I teach frequently is that once you have hold on the disc, don't pull it like hell, because sometimes you have to, with your hand, maybe you can see my hand, how I'm holding it. Sometimes you have to pull back 1 millimeter the cannula, otherwise your cannula strangulates the disc herniation and it breaks. To avoid this situation, you have to do that, and that's what I'm doing, trying to do. Rangeur, bitte.
I also noticed that you're using a lot of rotational maneuvers of your hand. I think in a lot of endoscopic spine surgeons, we rotate the disc fragment. It kind of like the torsional aspect of the rotation helps free it. Is that what you're doing? I kind of see what you're doing there.
Yeah, I try to do that. So I do this kind of stuff, right?
Mm-hmm.
But disc herniation is brittle. So see, now I'm trying to get it out. This is now, I have hold on it. The disc herniation, I got it, okay. Now I pull back a little bit my cannula because I don't want to strangulate it. It holds very well. I give the tissue some time. Now I have it, but you know, it doesn't, I got it here
Here
now.
it is.
Hospital. And now we have, you know, what we always look for, right?
Nice.
And that's basically it. And you know, the rest of the surgery will be looking at stuff, shaver bitte, making clear that the nerve root is good.
So Mazda, that brings the first question that everyone always asks. How do you know when you're done?
Well, I guess it's the same question when you're doing open surgery, right? No?
Yes, I agree. You know, there's a couple of things that I do. I like to make sure when I move the thecal sac, I look at the vertebral body below and above, and I make sure it's kind of flat. I mean, I don't know if you do that at all, but it's one little way to test to make sure there's not a bulge left in there.
True.
And also, obviously, I also go, whenever I'm done with this part of the surgery, I find myself spending 10, 15 minutes more just to make sure I didn't leave anything else in there.
Absolutely. You know, question is a little bit how clinically relevant is that, right?
Yes.
I mean, what I do, some people talk of pulsation of the nerve root and stuff. So let's visualize. So here is the axilla of the nerve root. Here now we see it nicely, huh? So this is basically the proof that we're looking at the nerve root because this is the axilla. And now we can go palpate, and I'm sure there are still fragments around, like here, right? And you know, now we can go in here, do our maneuvers, be careful with the maneuvers, not impinging the nerve. Sometimes I use the hook to kind of, you know, get rid of the nerve root. And then here we have basically the end. Oh, look, this is the annulus defect, and I'm now in the disc fully, huh? So that's what was expected, Rangeur, from the MRI. We knew that it's gonna be a connection, so it's not just a sequester, but it's a connection. And now comes the difficult question on, well, how much nucleotomy do you perform, right? And what do you do with the annulus fibrosus tear here?
Maybe we can have Luke's comment on that. How do you know when enough is enough, and how aggressively do you go into the nucleus?
Yeah, this is always a good question, and the common old school, you know, the controversy even in the microscope and to open surgery too. So basically, I prefer the principle is the fragmentectomy as much as possible. But when I see the annular defect, if just in case a large annular defect, so we need to avoid the reherniation as much as possible. So in that case, I try to remove the free fragment underneath the annulus, and also the additional tip. So using the radio frequency, I try to seal up the annulus as much as possible. But anyway, there's no single the perfect answer for that. But yeah, so decision. So I decided whether I go further with the more aggressive discectomy is in the OR under the visualization. Of course, in pre-op planning, we have the risk factor, some sort of modic change and obesity, and yeah, that's a sort of the another parameter whether during the period of pre-operatively, right?
So let me show you something. Here we have the annulus fibrosus defect, the nerve root, nicely protected. We're looking at the annulus fibrosus. You know, this tissue that nobody really likes. And even if, so we have to be a little bit careful because this shaver is actually designed for external work. But you know, when I'm in the disc, I do debridement of the free fragments. But this is not for around the dura really, right? But since now I'm in the disc, I'm in the safe zone. But you know, there are studies comparing reherniation rates when you do a full nucleotomy or not, and I don't think a full nucleotomy is needed, but debriding the free fragments certainly is a good idea. And then there is another trick, Rangeur gebogen. You might see, I don't know if you see it or not, but I have a curved Rangeur here that I can curve to any degree And Debbie will curve it for me a little bit more. You have to close it to curve it, okay? So I curve that, and then with the curved rongeur, you know, I can go in and get other fragments too, if they are any. So it's like a little bit, it's the same procedure like you do open, right? So it's not really different in this regard.
Maybe one difference in endoscopic discectomy is then if you have a direct view into the annular defect, the water jet also helps to flush out some free fragments.
Yeah, that's true, that's true. Okay, guys, so now I finish up here, and then we go and take a look at the nerve and see whether there are more fragments. So to visualize the nerve, I just turn my view here, and then we see the nerve, and then there are still fragments here, see? You know, everything is a little bit, it's not a nice disc herniation. Rongeur, so question is how much to remove, as always. So another trick, I would not bite like that. I don't want to bite something I don't see. So I turn towards me to see whether I have, there are free fragments. They are not. This is just annulus fibrosus. So here we can go now, Heckline. And you see how the nerve now pulsates and is deviated laterally. Remember when I entered, I showed you the lateral edge and I said that's bone. The nerve was far away. So the nerve looked totally differently. The nerve was like here, right? And now the nerve is here and we see pulsations. And I can now go in and check around. Look around the corner. So I'm palpating the pedicle here, so that's good. So done, huh?
Are there any questions from the audience?
Mazda, it's Constantine. Just a quick question. Is there any point in applying radiofrequency on the annular defect, doing like an endoscopic IDET for pain? Does it work? I
don't know. I know what you're saying, but I don't know. So question is whether if I go here with the, oh, look, another fragment rongeur. If I go here and I use my bipolar, right?
Yeah, right.
I don't really know because, you know, question is, does it help or doesn't it help? Because it might also impede the closing, the healing of the annulus because, you know, burning everything might maybe not be, it's certainly not good for, because we want this area to have a scarring, right? And if we burn, I don't know if that accelerates the scarring or it kind of reduces the speed of the scarring. So I don't know that. What do you think?
Would be nice to find a material that does welding, you know, we just weld the hole. That would be fantastic.
Tell me again?
It would be fantastic if we find a biomaterial which we can weld.
Absolutely.
You know. We used to do this with, they were trying this with meniscus repairs many years ago with lasers, but I don't think it worked.
Yeah, I see. Turn off the fluid now. So I want to just show you the pullback. So you see, no pressure anymore, nice pulsation. A little bit of, couple of erythrocytes, but you know. And then we pull back. You see how nicely the layers go back, no bleeding. If there would be a bleeding, I would coagulate, right? So 30 minutes for a procedure, which is not necessarily fast, okay? Because, you know, we had a lot of talk. We could have done much faster. So below 20 minutes is possible if needed for such a case. But the good thing is the skin closure is done. You don't need to spend time to do all this stuff. And the second good thing is that the rate of wound complication and infection is just like on the case report level. So very, very low. And that's why I can basically sleep well after this case. The only concern I have, and that has nothing to do with endoscopy, is the reherniation rate, right? That's the only concern I have. I'm going to come back to you shortly.
Thank you very much.
Thanks.